Good afternoon. My name is Paddy Kenny. I'm joint lead of the National Clinical Program for Trauma and Orthopedic Surgery, and I'm happy to welcome you to this webinar, which is a combined effort between the National Clinical Program for Surgery and the National Clinical Program for Trauma and Orthopedics. We have had a lot of IT innovation over the last number of years, and some of which, certainly in orthopedics, came more into practice during the COVID over the last couple of years. And we're excited to show some of this innovation today, and we've got fantastic speakers, and hopefully you'll enjoy it and be able to put into practice some of the things that we see here today. Thank you.
Well, good afternoon, everybody, and my name is Kenneth Mealy, and it's my pleasure to introduce our first speaker this afternoon, who is Mr. Richard Kerr. Richard is an honorary consultant surgeon at the John Radcliffe Infirmary in Oxford University NHS Foundation Trust. Richard trained in London, Oxford and Melbourne, and has over 40 years experience working in the NHS. He's got widespread neurosurgical interests and was earlier in his career renowned as being a co-principal of the MRC-funded international ISET study looking at the management of subarachnoid hemorrhages. This was originally published in The Lancet in 2005. Richard has been a lead clinician in the neurosurgical department at the John Radcliffe Infirmary, and also clinical center chair of the Radcliffe Infirmary. He's been on the board and has held numerous roles in the Society of British Neurological Surgeons and was president from 2014 to 2016. He's been a council member and trustee of the Royal College of Surgeons in England since 2013. And more recently, Richard has been renowned as the chair of the Independent Commission on the Future of Surgery, which was produced by the Royal College of Surgeons in England. And while this has had a look at many areas of technology, we felt it appropriate that Richard would be in a position to give us an overview of the future of technology for surgery and trainees. So we look forward, Richard, to your talk, which is Surgery in the 2020s, Implications of Advancing Technology for Patients and the Workforce. And you're very welcome virtually to Dublin, at least. Thank you, Richard.
Thanks, Ken, very much. That's very kind of you indeed. I'm delighted to be here. Let me just make sure we can see everything here. I hope everyone can see this now.
Yes,
so once again, huge thanks for the invite. It's a pretty broad topic to cover in a relatively short space of time. So what I'm going to do, if I may, is just talk about some of the areas of advancing technology and how that potentially might affect patients. And then I'm going to focus down a little bit on just some thoughts about how we can try to develop some of these areas and the concerns that arise from them. And then I'm just going to say a few words about a topic that actually wasn't covered in the commission, but I think is on everyone's lips at the moment, and that is the issue of sustainability and the green theatre. So the concept of a digital world for us to interact with is not new. It's been around for many years, and indeed was even popularized 20 years ago in things like this, using holograms as a concept of us using digital technology as to how we can demonstrate and interact in a way that we previously couldn't. And of course, that has been picked up by medicine amazingly quickly to the point where now in a virtual reality space, you can look at medical records, you can make medical records, you can annotate observations on patients, you can prescribe drugs, you can create discharge summaries, all of this in a virtual world that you can share with your patient. That has moved on so that we can actually create now in an immersive space pictures of areas that we may want to discuss with a patient or that we may want to operate on. Here you can see a beautiful demonstration of the brain itself and how we might utilize that both in the operating theatre but also in advance of being the operating theatre to counsel and consent our patients. You can then move that on, as I said, to a point where you can mix virtual reality and actual reality and give rise to a mixed reality platform in theatre where you'll be able to see what you're doing, but at the same time in a virtual space you can look at the anatomy and perhaps the pathology that you're dealing with, and others can see that as well, and you can interact with them. And that may be within these shores, or it may be across continents where people can interact in a virtual world at the same time. So all of this is potentially possible. It's made all the more possible by the fact that that technology is moving along very quickly from a situation like this where you are working with a robot in a training situation, in a simulation situation, to a position where, because of advances in connectivity, and in particular as we move into 5G connectivity, we can actually have a situation where the patient and the surgeon are remote from each other, in this case by 3,000 kilometers. Now, this was done 2 or 3 years back, where a patient was in one small part of China and the surgeon was in Beijing, and yet the surgeon, with the help of a robot and with a local team, was able to undertake a surgical procedure all those thousands of miles away. So this is not in isolation to medicine. This is happening across the spectrum, and this is called the fourth industrial revolution. And it's an advancement in terms of robotics, in terms of big data, augmented reality, cloud computing, and obviously the ever-expanding integration of the internet and integration within the internet. So, as Ken very kindly alluded to, I was asked to look at this in a bit more detail by the English College 2 or 3 years ago, and I set up a commission on the future of surgery. And the aim of that commission was to try to understand where we thought the major areas of change would be. And what it identified was that there were effectively 4 areas where the potential for change, not just digital change, but other aspects of change, would impact on how we deliver surgical care and surgery to our patients. And those 4 key technologies were, firstly, in terms of the use of genomics and the increasing use of genomics and big data. Secondly, the advancement of imaging through simulation into the immersive platforms of augmented reality, mixed reality, and virtual reality. The expansion of the rapidly progressing robot-assisted surgery in terms of minimally invasive surgery. And then there was a collection of other interventions which we put together, which we'll talk about. Now, what was clear is that the changes are going to be driven by 2 things that were happening. The first was the change in digital technology, and we're all aware of how quickly that's moved on. But the second was on a biological understanding of diseases and treatments. And I think it's really important that those 2 things are happening at the same time. What is clear is that it's going to affect every type of surgery, whether it's in my own discipline of neurosurgery or orthopedics, who we're going to spend more time talking about today. The hope is clearly that surgery will become safer, but also less invasive. And I think that, again, is something that we want to just talk about a little bit more. So what about the issue of genomics? Well, this is going to affect us at every stage of our lives, right from before we're even conceived to looking at disease and monitoring disease and disease processes all the way through. And I think the increasing recognition of how much genetics plays, not only in development of disease, the speed of development, the severity of development of disease, but also in terms of our response to that disease, even to the point of our response to surgical treatments for that disease, and even to the point of what is our potential risk of complications, may well have a genetic background to them. Now, there have been some fascinating concepts that are beginning to develop. For example, the use of liquid DNA technology, which I think is just fantastic. But the early detection and monitoring of disease may well be a possibility simply because of the liquid DNA. Now, it turns out that even meningiomas, which I've spent many years operating on, actually they can shed DNA into the bloodstream, which is detectable, even though this slide suggests that the blood-brain barrier may limit the ability of DNA to spread outside the head. But also the detection of resistance to aspects of disease treatment is all based on those genetic profiles. So the application of genomics is going to be of crucial importance. With that, I mentioned about big data. We have vast databases of information in the shores from public health records, from genomic records, from records as regards prescriptions, and obviously all our background electronic health records. I think we envisage a time when actually these large databases can be amalgamated and interrogated. And what that will provide for us is an unbelievably rich source of data where we can get to where we desperately want to get to, which is the provision of personalized care. So at an individual level, we want to know what is the likelihood of us getting a particular condition, of us suffering from that condition, what are the likelihood of the outcome of treatment, the potential risks, and the chances of recurrence. And whilst it's important that we know that for our fellow person, at the end of the day, we actually want that for us as an individual. So to move to personalized care is crucial and will come from analysis of large data sets. Now, I had the absolute pleasure of visiting the simulation lab at the RCSI, and this is a photograph taken from there. And the utilization of simulation as a training platform, not only for skill acquisition, but also for team training and development is crucial as we move forward. But equally, we can begin to see that that platform will change when we can start to do some of this in a virtual world in terms of those skill acquisitions. Now, there is a challenge then to know that the skills you acquire in a virtual world, are they transferable when we come to actually have to do that in a live patient? And I think that's something that we should always bear in mind. Obviously, acquisition of knowledge can be applied all the way across the spectrum here, from right when we begin to learn our anatomy and try to understand our anatomy in ways that we never thought possible before the advent of this immersive technology and the virtual space. So I think imaging, simulation, moving into virtual reality has an enormous impact. Now, we perhaps haven't even mentioned the biggest impact beyond that of teaching and training is actually the concept that we will be able to do our surgical procedures in a virtual world before we actually put knife to skin or put robotic portal to patient. So that the idea that we can practice this, we can do it in a virtual world and learn the pitfalls, the problems that we're going to face before we ever come to doing this on a patient. Now, when it comes to actually consenting the patient before we do that procedure, the ability to join them in a virtual world and to demonstrate the pathology, demonstrate the problems that we might face, and how that will help the whole consent process and patients' understanding of what they're facing. So I think this technology is enormously exciting and clearly is being taken up with great speed, but there are issues that we just need to think about. Robotics will be familiar to everyone on this call, and the increasing application of robotics. I think there is a popular misbelief popular misconception in many patients' minds that I think there is important that we do try to rectify, and that is that this is a procedure not being done by a robot working autonomously. This is a procedure being done by an experienced person who is working with the robot and using the robot, therefore, as a tool. The advantages of robots will be known to all of you in terms of their accuracy and the precision, their access to difficult areas of the body, the amazing illumination and magnification that comes with it, the clear benefits from the loss of tremor and the ergonomic comfort that comes from sitting in a much more comfortable position, and with it, hopefully, less pain and faster recovery times. However, there has to be more to it than that, and I think one of the hopes is that by using robotic assisted techniques, there will be less variation in outcome as we collectively become more and more skilled in their use. But it comes with a price, and the price is the cost, the instrumentation costs, the portability of some of the bigger machines, and of course the training time and associated costs. There is also the issue of evidence of effectiveness, and there clearly continues to be debate about that, perhaps less so in the world of urology, where robot-assisted techniques, particularly robot-assisted prostatectomy, has been around for some years with many patients being treated in that way. And I think the evidence of effectiveness is there, but the data is being collected for other disciplines. Nanorobotics, just I mentioned there. What about specialist interventions? Well, these are what we picked out in 2019, and it's interesting that you will have heard of in the news recently about the xenotransplants for a gentleman who's received a pig heart, and there was also transplantation of pig kidneys into a patient. So xenotransplantation, which was, if you like, being thought about just 2 or 3 years ago, is now coming into being. There are other areas here like stem cell therapies, and there's even suggestions now that we will replace lens replacement for cataracts with stem cell replacement, and you regrow a new lens in due course. Many areas of change are therefore potentially around, and what this will mean is a huge impact for patients, and it will change their healthcare journey, and the journey, which is a cycle from healthy patient and prevention all the way through to disease follow-up and management of long-term conditions, looking at recurrence. And I just summarized there on the right-hand side of the screen the sort of things we're talking about here. We're talking about much more attention to prevention of disease. So in other words, looking at health rather than disease and trying to prevent disease, predicting those who may suffer disease, much earlier diagnosis, better preparation in the terms of prehabilitation, organ sparing surgery rather than organ removing surgery, and then better rehabilitation post-surgery with an amazing array of potential methods of monitoring patients for their disease processes thereafter, even using nanorobots that we've talked about, that I mentioned just now, in terms of using them to detect tumor recurrence, changes in cellular chemical composition that may allow us to predict early recurrence of disease. To achieve this, there will be changes in the way that we as surgeons operate, but I think the concept of the future surgical team will only ever increase. Procedures potentially may become more complex and specialized, and there may be some interventions that require a really complex surgical team that I've described there. So how will the surgeon change? The surgical career almost certainly will become less distinct and hopefully more flexible, and I think we must all welcome that. We will need to learn the language of some of these things, particularly genomics, if we're going to interact with our patients and indeed other specialists when we come to deliver these. Team working, as I mentioned, is going to become even more important in the future, and the concept of a greater role for non-surgeons, particularly if we're looking at competency-based delivery of care as opposed to simply surgical delivery of care. So what about surgery in the 2020s then? That was the title of this talk. Well, I think the core demands for surgery will always remain, and they are core demands. So careful assessment, detailed analysis and consent, precise surgical procedures, required follow-up and monitoring, collaboration, compassion, mentorship, team working with the patient central to all aspects of that healthcare delivery. What is new is the application of digital technologies and the impact of other technologies. And the issue then becomes is to understand how and where we apply these, to develop the required training and ongoing assessments for not just the surgeon, but all members of the surgical team, and also to put in place processes that enable rapid but safe adoption of these changes, which are coming in so quickly. So that's the challenge that we need to consider. So how are we going to achieve this? Is this going to be by default, or is this going to be by design? Now, to some extent, some of these things have already arrived, and it is largely by default. COVID, I think, has driven a lot of change. So if you had spoken a couple of years ago about online consultations and telemedicine, I don't think we would have recognized that in terms of how it's now happening, which is oh so frequently. The online prescriptions that we now all enjoy, we don't have to go and see our GP to get those prescriptions. It all happens there. The drug is delivered, or you go and pick it up at the chemist. The pocket doctor and the availability of information that is there, whether it's Google Care or Amazon Care, these are amazing repositories of data and information that's available to all of us. And it's because of the immediacy of how we lead our lives, it's available to us on a 24/7 basis. Whether they're good things, whether they lead to concerns and anxieties that aren't well explained by those sources of data is a different issue, but it's there. So these things are happening, and to a large extent happening by default, but we do need to try to moderate this, I think, so that we have some design around how they're introduced, how they're managed, and how they are reviewed as we go forwards. If you look at the Topol review, which was commissioned now just 3 years ago, almost to the day, this was published about preparing healthcare for the digital healthcare practitioners for delivering the digital future. What that talked about was the need for changes in the surgical curriculum, about knowledge of IT, data, about acceptance of training, career flexibility, and so on, and how this would apply to the whole workforce. What it didn't talk about was, okay, how we prepare the workforce, but how do we actually begin to deliver some of these changes? How do we bring them into practice? How do we know that they're the right thing to do? So what I want to do is just to consider a couple of areas that we've looked at through the RCS England by design rather than by default. And what we've been doing is looking at aspects of robotics and minimally invasive surgery and working with the commissioners, thinking about developing teaching accreditation platforms, doing that with the robotics companies who are so involved with that already, considering reviewing the national data sets for robotic procedures and try to understand how good and how complete those data sets are. And in particular, what are the hotspots where robotics is being done and why is it in those places and not in other places? Whatever we do in terms of delivering these changes in care, it needs to be accessible to everybody, and we have to understand why it's happening in some places and not in others. What we set up was a robotic and digital surgery initiative with colleagues Simon Back and Naeem Sumro, particularly with input from the NHS and the government, Health Education England, some of the surgical specialty associations, and obviously with industry as well. And in particular, we looked at two areas which are defined here as mastery and reinforce, and I will just briefly mention these. So mastery is a study that we've set up, basically measuring the quality of surgical care and setting benchmarks for training using data recorder technology. So this is basically trying to address, if we are teaching and training someone using a digital platform such as a robot, what are the issues that we face within there? What are the potential benefits? What are the barriers that we might face in developing and then investing in this sort of technology? Now, there's a recognition that the evolution of minimally invasive surgery is going to come, and it's coming very quickly already. And it does potentially open doors to new opportunities. And we've listed some there in terms of patient safety, better surgical practice, and equity of access to these techniques. But we need to be sure that the teaching and training that is being done and the acquisition of skills is as we think it's going to be, given that these skills are being acquired in a rather different way. So this uses an automated performance metric, or APMs for short, as a way of trying to collect data about how people acquire digital dexterity skills. And you can see it on this slide here, where this is looking at movements of the tip of the robotic arm in terms of roll, pitch, and yaw, the three different methods of movement. And if you look at someone who is very experienced, you can see the graph, the 3D graph on the left there, where their range of movements is actually very minimal, where someone who is much more inexperienced, their range of movements is huge. Now, how do we move from one to the t'other? What are the things that we need to learn within that? And how can we use a digital platform for us to try to learn that? The second thing we're looking at is something called real-world evaluation of robot-assisted surgical services, or reinforce. And this is being done with Marion Campbell in Aberdeen and David Beard in Oxford. So the concept here is that if we are to use robot-assisted techniques, are we to try to develop some general principles about their implementation, or is this something that's simply going to be taken up by those who are particularly interested and see the benefits of them? So this was a study that's ongoing at the present time to try to look at the rollout and embedding of this new technology in everyday practice. And this is using something called a step wedge evaluation, which is a form of randomized controlled trial, but it simply means that if you say had 20 centers, then you start this rollout in one center, and a time later you start in another, and a time later. And this is a step wedge evaluation as you begin to look at the introduction of robot-enabled surgical services. And this is being done across a whole series of sites across England. So the aim, hopefully, is that we can begin to look at the impact of engaging with robotics in terms of clinical delivery, in terms of effectiveness, in terms of cost, and ultimately, therefore, in terms of efficacy when it comes to delivering the service. So these are attempts to try to rationalize and understand how we introduce some of these techniques rather than the techniques just being rolled out because they can be. So the work packages that go with Reinforce, the first one was to look at the barriers and facilitators to implementation of this. The second is then introduction of this across a whole series of sites. And then obviously the last part of it will be to understand the mechanisms of change and then put it in the public space. So that's just a sort of a very quick run through of some ideas that we're trying to develop looking at minimally invasive robotics. Now you can take that sort of concept and you can look at it in lots of different other areas that we've talked about. So what about teaching and training that we've talked about? How much of that can be put on a digital platform? How much can we use immersive platforms in skill and data acquisition? And how can we check that our ability to acquire data in that form is as good as or better than the way that we've acquired knowledge before? How can we test effectiveness? What about with patient interaction and consent using these platforms? Exactly the same thing. How much of that consent process and data transference to a patient can we put onto a digital platform? How much can we use a virtual reality platform to advise the patients about the problems they have and gain their consent? And then if you look at that from a surgical perspective, how can we be sure that the transference of skill that we've learned in a virtual space into a real life situation is it quicker? Is it better? How can we measure that? And I think once we begin to think in those terms, then it is et cetera, et cetera, et cetera. It's everything that we begin to look at. So I said right at the beginning, and we've just got a few minutes left, that I just wanted to say something quickly about sustainability in the Green Theatre. And I want to just thank Chantal Rizan, because this is her work. She's an ENT reg down in Brighton who's done some amazing stuff looking at the environmental impact of surgery. And this has been picked up by a sustainability group at the college where I'm based, and in particular Mood Bhuta, who's the professor in ENT surgery down in Brighton, also very much championed by Stella Vig and Victoria Pena, and supported by both Neil Mortensen and Derek Alderson before him. Some extraordinary stats here. So globally, we put out 2 gigatons of carbon dioxide into the atmosphere. And if health, this is the footprint of healthcare, if health were a country, we'd be the 5th largest emitter of carbon dioxide into the atmosphere at a global level. Now, if you take that just down to England, it's almost 25 million tons of carbon dioxide is emitted. And health accounts for 4% of greenhouse gas emissions in the UK. There is a plan that should be 0 by 2040. So that's 18 years to go from that to 0. Big ask. What about the operating theatres where we all work? Very intensive area in the hospital, 3 to 6 times more energy than the rest of the hospital, and it generates a quarter of the regulated medical waste. Single operation in terms of carbon footprint is equivalent to driving over 2,000 miles in an average car. amazing carbon rich from what we do. Why? Well, energy, electricity, consumables, and anesthetic gases all contribute to that. What Chantal has suggested is that there would be a sort of pyramid of things that we can begin to look at to make surgical practice more sustainable, starting at surgical disease prevention at the very bottom. If you don't need an operation, you're not going to incur these sort of carbon risks, and then through patient education, empowerment, eventually, and then getting to reusables at the top, and then maintenance, repair, and recycling. So patient empowerment, disease-specific lifestyle, optimization, and so on. And this is being linked with GERFT and also the American Board of Internal Medicine Foundation called Choosing Wisely has been looking at this as well. Reuse, there's a lot being written about reusables. When I started in practice, most of what we did was reusables, including our gowns and so on. And obviously we've moved to a single-use world, but there is now a call to switch back to reusables because of the impact that that is having. And Chantal's come up with a list of top tips for operating theatres when it comes to reusables. I think this is all being brought very much into focus just today when we heard about the impact that the use of single-use plastics and single-use gowns in terms of the COVID pandemic has led to the WHO reporting tens of thousands of tons of medical waste are now putting huge strain on healthcare waste management systems around the world. So I'm going to leave you with that slightly sobering thought. Once again, thank you for the invite, and I look forward to the discussion very shortly. Thanks once again. Thank you.
Richard, thank you very much for your presentation. Really exciting future that you paint, notwithstanding all the challenges. I have lots of questions, and I'm sure many others do, but we'll keep those to the end of the session if you wouldn't mind. And I will ask Paddy now to introduce the next speaker.
Hello, Ken. Thank you very much, Richard. That was an excellent talk. I just can't get my camera on. Sorry, thank you very much, Richard. That was excellent and very thought-provoking. It gives me pleasure to introduce Yvonne Goff. Yvonne is going to speak to us about a cruise strategy and the health visualization platform. I've met Yvonne a few times. She's the National Director for Change and Innovation in the HSE, with responsibility for major reform programs, including acute services, older person services, disability services, mental health services, and digital innovation. In a former role, she was the HSE Director of Integrated Information Services. Yvonne has had a leading role in some of the largest e-health projects in Ireland to date, and has significant expertise in major project delivery and change management. She is committed to enabling patient-centric innovation and continues to be a champion for data-driven solutions in healthcare. She's a very busy lady, and I'm delighted that she could get the time to join us today. Thanks, Yvonne.
Thanks, Paddy. It's very unnerving hearing your CV back at you, but thanks very much for inviting me here today. I'm delighted to be here, and it was very interesting to hear the last presentation. So I'm not going to take very much of your time, because what I'm bringing to this presentation today is our solution to looking at data in terms of consolidating data that we already have. So, as Paddy said, one of my roles is reforming the various elements and leading that reform. And one key area is the reform of scheduled care and looking at all our waiting lists. And when we looked at all the challenges we have around that, one of the key things that kept emerging was our access to data and our access to information, and not just centrally, but really from a clinician perspective, to have real-time information at your hand so that you could make informed decisions and you could plan and measure the impact of your interventions. So I'm going to talk about how we went about doing that and what we're trying to do in terms of implementing that. So we went out to market and we identified a solution, and the CEO, Martin Connor, is on the call here today and is going to present a solution that we have contracted with to go out to 28 of our hospitals. We did a proof of concept in Kappa, in St. Vincent's and in Mullingar to test the solution. And I'm really delighted to say that yesterday we went live with the solution in Sligo. So it's and you'll see for yourself, it'll speak for itself when you see the presentation. And I'm very happy to take any questions about that. You know, one of the key things for me is about the importance of having the right information at the right time. And a former role I had was in the implementation. I was on the implementation team for Nimitz. So I'm really happy to see, you know, two of the presentations here are talking about Nimitz, I hope in a very positive way. But yeah, and so it just proves to you and all of us the importance of data and the importance of having the right information. And to allow us to drive clinical decisions and better patient outcomes. So without further ado, I'm going to hand over to Martin Connor, the CEO of Healthcare Logic, and we hope to have this solution in place in 28 of our hospitals before the end of September this year. So welcome, Martin.
Okay, so I hope that people are seeing my screen now, eh?
Yes, we can.
Okay, lovely. Okay, well, again, a fascinating first talk. I hope I can live up to that standard. I'm Martin Connor. I'm an adjunct professor. I was full professor until 2017. I've been working on what I'll show you now for the last 4.5 years full time, and I'll just spend 5 minutes on the conceptual background and just 10 or 15 minutes showing you the platform that we've been developing, and as Yvonne says, is in the middle of the rollout at the moment. So we all know that there are problems of data. The particular data I want us to think about and focus on is that related to queues or capacity and demand or productivity. And this type of information is slippery in its way, sometimes difficult to get a hold of, difficult to analyze, and difficult to interpret between sites. And one of the ways we can get around that is through the use of automation and much higher frequency feedback of the information that's being collected in clinical and operational processes anyway. So our goal is to use the data that we're already collecting and leverage that for the insights it might provide. And big data is a theme of the last talk, and that's very much what we're and analytics very much the space that I'd like us to focus on now. And we know that policymakers and investors in public systems, major focus for me is public systems. I'm 20 years in that space, is about getting access to timely and consistent and accurate data from hospital groups and hospital sites. But of course, we all know that within those hospital groups and sites, there's a similar problem getting access to information that can connect the right conversations between local leaders and clinical teams. And as we know from our quality improvement insights, it's only the work of those clinical teams that makes a difference. And so if we can't close the gap between policymakers, investors, local leaders of sites and groups and teams themselves, we're in a difficulty trying to create a common language. And that's what the health performance visualization platform program is designed to do, is try and build a common language between these different elements of the system, all of which are important in their different ways, but oftentimes there's a challenge in enabling them to communicate effectively together. And again, focused on productivity and capacity and demand, which is ever more important now in the light of the even larger queues that have built up as one of the inevitable consequences of the pandemic. So the technology, automation is fundamental, very high frequency data. We're interested in record level time series, and we want to make it available at all these different levels of the system so that we can close the gap of insight and get a much stronger situational awareness. And I'll show you, I won't labour these points because it's better to show it rather than say it too much. And ultimately the human factors of the system are really the target of trying to introduce more data-led decision making, because we need to build trust in the information itself, of course, but also trust between those different levels of the system, which is a lot of which can be built through a stronger common language. And because we're humans, of course, we need stories, and until we get our numbers right, it's hard to know which story to tell, because we know there's a profound difference between a team that's struggling with an overall capacity and demand imbalance and a team that might have its capacity roughly where it needs to be, but is struggling with some system or process issues. And knowing which one of those issues is the most important for each situation is an essential part, really, of moving us forward. And it's a very exciting time, not only in the medical care, health record, personalization technologies, but also just in analytics, and server power in the cloud are really increasing the scope and ability of what we're able to do. And some of the technology we've built following about 4 or 5 years of R&D, the stuff we built in the last 3 years, has only become possible because of the technologies that are currently available. So I won't spend too long on this, but essentially the idea behind the program is to automatically extract data at 5-minute, hourly and daily intervals. So out the back of the hospital patient administration system and schedulers, absolutely rigorous commitment to confidentiality and patient privacy and the privacy of that data. So identifiable information available only to those authorized by the hospital to see it at the higher levels of the system, anonymization protocols in place to ensure that no personal identifiable information is visible at all. And then from across the hospitals in the group and national network, we can then bring that data together into a single Azure instance. Interestingly, through the ransomware attack, the Azure instances were the ones that were least affected, partly because of the massive investment that goes into cybersecurity from Microsoft and other providers. And then one of the ways we've tackled the solution of the huge variety of systems in hospitals, which bedevils us getting a consistent view, is by the quite painstaking development of a minimum data set. So it's been estimated there's about 9,000 data fields in a typical hospital, medium to large hospital PAS. We think there's only about 450 that are really needed to tell the stories that we want to tell, but which 450 of the 9,000 took a long time for us to elucidate and describe. And that's where we are now. And that's what enables us to move relatively quickly towards meaning from the backdrop of data that's being collected. And also in our favour, as everyone on this call will know, there is a high-level pathway. And over the last 40 years, there's been a huge investment in different systems, a huge variety of flora and fauna of technology capture systems, as we know. But in scheduled care and unscheduled care, there are now databases running across all of these elements of the high-level pathway in every medium to large hospital, and that is something that we can leverage. And we did a lot of studies in the very early stages of the program to ensure that the data was there and that it could be acquired. And then finally, one of the big challenges has been develop an interface that's intuitive and easy to use, because the healthcare hospital data can be very complicated. And we also we set ourselves a challenge of making something that was interactive and personalizable, because even though we might want to generate millions of charts, we might be only particularly interested in 4 or 5, and we want to have those highly available to each individual user according to their local needs. So I'll stop the presentation there and just share with you what it is that we're proposing to put in place. So I hope you're seeing the screen now with the this daisy chain, as we call it. This is our proprietary navigation system. We spent a long time co-designing with clinical teams and executives. And essentially, we click a petal on the screen. It's impossible to get lost. We can go backwards and forwards simply by virtue of moving up and down the graphic. And then the petals will expand and show us what lies beneath. So the scope of the program that we currently have underway is for outpatients, that's clinics and lists, surgery, theatres and lists, the emergency departments, beds across the hospital, and medical imaging, most places on Nimitz, AGFA, and a couple of other systems that we'll integrate with as well. And essentially, sitting behind this, there's about 70 different analyses, but I'll only just go into a couple, and you'll get a flavour quite quickly of the types of things that we're able to do, bearing in mind that all of that data is automated and will typically at the oldest be yesterday's information, which we'll download overnight. So focused on surgery, obviously, today, and we've been thinking about the waiting lists for many years. And if we click into the trends of the waiting lists, the basic idea is we want to look at the overall system and then be able to get down to the details, ideally with some analysis of risk, capacity and demand along the way. So here's a classic chart of 12 months worth of data, where every data point here is the overall number of patients waiting at a hospital site, and every data point is 1 day. So we carry 12-month window and move that along. And that's that at an overall hospital level is not that interesting, but it does get more interesting. We get into the individual teams and we can see the distribution of the numbers of patients in each team, and then we can get down into the urgency rates within each team and look at the distribution of patients on a list as of yesterday for each of the doctors in that team. So we'll use gynecology as an example, and we've got one surgeon here. All of this data is synthetic data for the purposes of the demo. One surgeon here with 109 patients on the list, and we can then see the trend of that individual surgeon's data over the last 12 months as well. So we're starting to very much personalize the information that's available, so we can start to tell stories about colleagues whose lists are rising or falling, and also about the capacity and demand. And I'll talk briefly about the analysis that we have running about that. But then we also want to be able to get down all the way into the list, as it were, and be able to call out by cohort all the patients who are currently listed. So I clicked into the second most frequent procedure on this synthetic surgeon's waiting list as of yesterday, and we can see here all of the patients with all of the types of information we might want to have available in order to either change a booking or run an audit, and we can activate these patient record level views so that we can export them into Excel and possibly use them for other purposes as well. And we have a nice feature here where each user can select the actual column headings that they want to have downloaded at cohort level, either by time or through procedure, so that we have fully curated data available at record level as a direct extension of the analysis that we can see higher up in this particular component. And then I just want to briefly share we have dynamic capacity and demand analysis that we do for each surgeon, and we've done this by calculating and developing a nominal waiting list maximum algorithm, which enables us to use each individual surgeon's treatment rate to calculate how many patients they could have on their list and still have a reasonable chance of treating them all in time if the future was like the past. And so each surgeon gets a panel like this where we can click and see treatment rates in the last 12 months and the corresponding averages. And from that, we can say for each urgency rate, how many patients is it reasonable for this surgeon to have? And because we're curating the data and automating it, we can compare that with the list as of this morning and come up with a risk assessment about the extent to which each individual member of the team might have a capacity and demand risk. And we published this algorithm in the Journal of Health Administration in September the year before last, with a set of case studies and full working out of the logic of it as well. What's interesting here is that we can click across a team and see different phenomena. So here's a case where the nominal waitlist maximum or estimate of what a surgeon can carry is higher than the actual waiting list. And so there might be a chance to list a few more patients with the same amount of theatre allocations for this colleague. But of course, sometimes we will find individual colleagues within a team whose waiting list is significantly higher than our estimate. And this situation is likely to introduce introduce a performance challenge later on. And we want to be able to interact with the data as well. So in this case, this surgeon has, say, 65 patients on their list at this urgency category today. Our estimate is that they should only really be carrying 39. So if we wanted to improve that, we can click the improve button and we can get asked, where do we want to get to, and how long do we think it might take us to deliver this change, and then have we got tolerance for variation along the way. And then actually we can ask System View to send a notification and actually watch the progress of this list to see whether the project we established to improve things is on track or not. And when we press finish there, that then is a part of the this individual users chart array that they can return to the next time they log on. And I'll show you briefly at then how that might work. And then as a clinical director, there might be different functions you're interested in. So if I'm interested in my most recent or my most urgent patients, the ones particularly in cancer risk specialties, I might want to set up an alert here to make sure this doesn't get out of hand. So we can see here, this is the category 1 gynae patients over the last 12 months. We can see this list is reasonably well controlled. We've not got long wait patients. Occasionally we get 1 or 2 popping up. And in this case, we might want to just set a threshold here to keep an eye on this. So we can set a value anywhere we like based on the actual data, of course, in the last 12 months. And again, we can set an automation there to say, if there's ever 3 or more patients on my most urgent cohort waiting too long, then send me an email or a text message, and we can turn that off on the weekends if we want a little bit of peace and quiet from the anxiety. But the point there is that we can establish the system from the desktop to keep an eye on things using our own personal control limits in a way that hasn't previously been possible. And I'll just show 2 very quick functions and then the personalization, and then I'll finish. Obviously, waiting lists are only a part of the story. Capacity is very important too. So we did a lot of work about how to visualize what's going on in theatres. So what you can see here is 6 weeks worth of all of the available theatre time, represented by a pie chart per week. The dark blue regions are minutes that we've already booked, and the light blue regions are minutes we still have to book. And again, if we want to keep our metaphor of the gynecology clinical director, I might be interested in just my gynae sessions. And here's the particular profile, almost everything booked this week, thank goodness. And then I've got about 1/3 of my slots time available the following week. And then in the week after, I've got 2/3 of time available. And in the same way as with the list, we want to click into the week and we can see all the sessions that are actually available. And we can click into the sessions and see which patients are currently booked. And we're automating the data flows from here each hour. So we know the session lengths. We calculate operation length estimates for each individual surgeon, which enables us to have a running total of the minutes that are available in this session. And because we've automated the information from the waiting list, we can bring all of the unbooked patients to the top and apply a 3-stage algorithm, which is how urgent does the system, have we recorded that this patient is, how long do we think that this procedure will take the surgeon to do, and how close are we to breaching any of our waiting times. And so all of the things being equal, we'd book this patient into this slot in order to optimize our chronological management and utilization. And then the final function to show you just 3 of the 70 some that are in here now is just to answer another one of the long-standing questions about whether we're using our resources effectively. And again, we start with the whole system, a hospital sites, where the blue here is actively used minutes, and the pink is unused minutes. And again, interestingly, when we go into individual specialties, because we can see now the specialty trend of used and unused minutes over the last 6 months, where each of these bars is a week, and we can go down to individual surgeons as well. So I click into a colleague's name here, and I can look at the last 6 months of individual sessions that have been done, and this enables us to begin to find the stories about what's actually going on underneath the hood, as it were, that might be driving our utilization. And we can see here different patterns of data. Here's a day where we had three patients booked and 3 patients done, and then in the week before, a very busy day where we had 7 patients booked and all 7 came in, some variation in the times, and we squeaked in at the end of the session. But then there might be other times when we can find some very low utilization rates, and again we can tell the story here. In this particular case, we had 3 patients booked. This is what actually happened in terms of the journey of each of those patients through the time in the theatre. And here's the anaesthetic track, and we can see here in this case underbooking this session led to underutilisation. But it's the ability to tell those stories at individual surgeon level and individual capacity moment level that enables us to take a step forward in terms of understanding where the opportunities for improvement or the requirements for investment might be. And one of the big things I spoke about at the start was about the ability to personalize. So you saw that I interacted with two of the charts during the demo, the waiting list one here and the let's keep an eye on the urgent cases here. And this is a Netflix shelf behind the button. Again, every user gets a personalized version of this, a little bit like the way that Amazon will remember you the next time you log on, and people who bought this book might also like this book. In system view, we're able to just capture for each individual the charts they're interested in. We can do this at team level as well, and individuals can create their own projects, and we can generate hundreds of millions of charts. But if I'm only interested in 2 or 3 charts, I can create a project from my desktop. I can add any of the charts to that project, and then the next time I log in, I might not go into the explore space. I might just go into my projects, and here's the disaggregated data with any thresholds that I've added to that data available to me at the latest time period. So these will automatically update each day at that level of disaggregation. So every user can select a subset of charts for a quality improvement project, for example, and have that information straight away available to them. And then we're also able to export not only to Excel, but also in this case we can take the charts out, and this is a function I've often wanted, to be able to get away from the control seeing and the control viewing late at night. The system view will automatically create a PowerPoint presentation of any of the charts that we've selected to be in our personalized projects, and have them available for colleagues for any further discussion that might be required. So that's a very, very brief whistle-stop tour. Thank you very much for the opportunity to present. I've shown you a tiny portion of what's available, and as Yvonne said, we're very excited to have the first site live yesterday, and we're on a journey now to make this technology available across the hospital network, with a view to them enabling a new set of conversations based on the truth of the patient level data by risk and by cohort, available at all of the levels of the system, hopefully to improve the quality of the conversation as we go. Thank you very much.
Martin, thank you very much. Another really exciting talk. So we now have 10 minutes for discussion, and perhaps, and just the attendees, I think to the right-hand side, you will find a chat function. So if you can type in your questions. Having said that, currently I can't see the questions, but perhaps some of our administrative support will be able to help us there. But perhaps I could get the ball rolling and ask maybe all of the speakers, Yvonne, Martin, and Richard. Richard, you had a phrase earlier on talking about new technologies and introducing them by either default or design. And I think both Martin and yourself talked a little bit about design, how you can introduce these technologies. Could I bring you back to that and perhaps talk a little bit about change management here? Because if you look at stress and burnout, certainly in North America, a lot of it's tied into electronic health records and the amount of time doctors have to deal with new technologies. Have you any thoughts as to how perhaps, and I'm saying this as a semi-retired individual, perhaps it's easier for younger individuals, any ideas though as to how we can design processes that will be user-friendly for healthcare workers into the future?
So I think that's an extraordinarily difficult thing to do. My reason for talking about default or design is that I think that where we want to get to is by adoption of new technologies by design. So in other words, they have been tested and verified to know that they actually deliver what we want them to, as opposed to they simply come by default because an interested party has a particular fascination for a new type of technology or a new piece of kit, something that's shiny and new, and we really like to use that. And you know, I'm sure, Ken, you were the same. We always like to have a look at these things, but we need somehow to get past that and understand the value of that new technology and how we can introduce it safely, but to get the most out of it. And I think that's a real challenge, particularly when things are moving so quickly. So if you stay with robotics, the number of robots that are arriving in departments is increasing incredibly rapidly. And yet there isn't a planned rollout of how we should do this. There isn't anything in place to make sure that it's happening with equity across the country. And the training that's done is done superbly by the companies with some highly trained surgeons as mentors, but there isn't a defined curriculum behind many of these training programs before they're rolled out. So I think it's a real challenge. My worry is that we're hanging on to the shirt tails of something that's already happening, and it's going to be really difficult for us to claw that back.
Thanks, Richard. And Martin, you alluded to performance management in a very granular way, which I think a lot of doctors may find challenging. How do you think that healthcare management can deal with that?
Yeah, it's a great question, and I think the last 40 years has shown us all that there are positive and negative management styles and management approaches. And I mean, Ireland's led the way in the introduction of quality improvement training, I think, in a lot of its professional colleges and other networks. And I am a believer that the system we've developed is based on a quality improvement methodology. And I think to automate the availability of the data needs to come alongside an understanding based on professional respect and appreciative inquiry, and then ultimately to take the collaborative model where lessons can be learned, insights, and then shared between sites. And I think one of the problems we're trying to solve is providing a backdrop of consistent data so that that collaborative model can be leveraged. But I think the days of top-down performance management are over, and one of Dean Sullivan has made that point very strongly in his introductory comments about this is about bottom-up, a collaborative approach rather than a top-down performance management. So I think on the one hand, I think we have to be mature enough to accept the necessity of granular high-frequency data. And on the other hand, I think we have to ensure that that is met with a style of professional respect and appreciative inquiry. And I think if we can stay in that quadrant, I think we can make a difference.
Thank you. That's a very sensitive response to that question. I could keep asking questions, but I'm conscious that I cannot see the chat function here. So, and I'm sure there are other questions. So have we any administrative help?
Yeah, Ken, I can see the questions, and there is a question from our president. There's a question. Can you hear me?
Yeah.
There's a question from our president, Professor Ronan O'Connell, and he has asked, performance management is all well and good when there is unfettered access to admissions, but this is where it breaks down time and again. So, Martin, you know, we have difficulties currently in the hospital I work in, extreme difficulties in even getting patients into hospital. So, you know, does the data, do you feel, provide a solution to, or a method where we can find a solution to this problem, which is a huge problem in Ireland every winter?
Yeah, and I don't think it's a magic wand solution. I think that there's a whole nest of things that has to be sorted out there in terms of the hot and the cold and the management of trauma and how we can improve how we can improve the delivery of services for populations. And I think the groups are one way in which that can be done. I think what the data is very powerful for is identifying variation and identifying variation at different levels of the system. And it is very clear that when we have individual surgeons whose caseloads are frustrated by the admissions problem, we have to develop ways to interrupt that and find alternatives. At the moment, in the legacy, it's actually very difficult for us to develop a common language to say, of this team of 6 doctors, it's these 2 that are experiencing these specific issues, and to this extent, and it's affecting this type of cohort, and that gives us many more signals in order to develop more granular solutions. And so I think by itself, no. I think I would describe it as a necessary but not sufficient part of the recipe that's going to be needed for reform, sometimes in teams, sometimes in sites, and sometimes between sites, and sometimes about net capacity. And so I think it's necessary but not sufficient.
Thank you, thanks, Martin. And I think with your solution, hopefully we'll be able to track where theatre availability is and maybe move patients towards the theatre availability. There's a couple more questions. Mr. Hafsa Khalid, this is a question for Richard, and again, Professor O'Connell has a similar themed question. Can robotic surgery replace manual surgery, and should all surgeons be trained to a level of being able to do robotic surgery?
So I think that robotic surgery should be an integral part of every training program, and I think there are stages in acquisition of the skills of utilization of robot-assisted surgery. There will be some instances, clearly, when robotic surgery is not appropriate, and that may be, that will vary between disciplines, it will vary between individuals. And I think the system needs to allow that variation to occur. So I don't think there's every operation, every particular type of operation should be done by robots. That's not how it should be applied. I think that there will be some individuals who become highly skilled at performing robotic assisted procedures, and I think that's really important. Indeed, one of the big debates, one of the big discussions is what happens when you need to transfer from a robot assisted procedure to an open procedure. Is there an issue about the skill level of the individuals who will be able to do that? And I think the feeling at the moment is that yes, there is that skill level there. And that's something we just need to keep a watch on. But so yes, I think robotic assisted surgery should be taught through the curriculum. Everyone needs to acquire a level of skills, and then how they're applied later on will dictate how much further they go in that form of training.
Thank you, Richard. I agree, but I don't think robotic surgery will take over everything as you suggest, and we will need some surgeons to do.
Absolutely, I agree.
Yeah. Okay, I have another question then, and this is from Jerry Kelleher, who works in the College of Surgeons. And Jerry, a question to you, Martin. Jerry's concerned about the support that staff will have moving from paper-based models, which we have in most of our hospitals now, into the digitized model. And I presume there's going to be a lot of training and counseling, etc., for this to happen, because it proves very difficult even for the smallest of things, I've found. Martin.
Yeah, there's no doubt about that. I think that one or two advantages of the HPV program, one is that it will automate some of the manual repetitive tasks in terms of producing the standard analysis that's necessary for us to understand what's going on. So there's some supports that I think that can give, and you've seen the intuitive nature. So we're trying to do part of that by design as well. And then secondly, I think the program as it's designed includes a team who is dedicated both to the training and the adoption and the strategic change management. And I don't know if Yvonne wants to make a further comment about that, but we're certainly investing in those skills, and the HSE is as well. And so the introduction of a data-led environment with a common language, I think will enable us to leverage a lot of the existing resources. And there are specific resources allocated for the change management training and support process as well.
Thank you very much. If there's no further questions, Yvonne, you might give us the last word on this section of the meeting.
Yeah, then thanks, Paddy. I just wanted to come in on a couple of things there. So, Ken, for your question around the change management and implementing e-health and so forth. Richard, you mentioned the kind of the lack of standardized approach in terms of robotic, and so one of the things we're trying to do for all our programs across the HSE and implementation is learn from previous programs that have been implemented, and so we'll hear from Nimitz later on. And one of the key successes for Nimitz, we did an 80-20 rule, where it was 80% configured and 20% for local customization. So you have enough standardization to allow all the key integrations, but you would also look autonomy locally for flexibility around making it work for you and your environment. And, you know, sometimes it should be more near 100%, sometimes it should be less. But it really is, to get the buy-in, you need to have people involved from the beginning, and they need to be part of the answer and to work for them, or else they'll find a workaround. They always do. And then, you know, you won't get the true value from the system if they find a workaround. In terms of, you know, the system we're putting in health performance visualization program, we've learned from them. So we have that change management in place. So as we roll out, the technology will go live on day one, but there'll be change managers working with the managers and the clinicians and so forth to make sure that that is embedded and we can continue to learn from that. And I suppose the key part in terms of our performance management is we don't have the data. We're operating blind, and we can't have those respectful two-way conversations. And there's, you know, there's a lot to do with trust. And so as we start sharing the data, we can compare apples with apples. We can identify those pinch points at the local hospital level, at the local team level, and have respectful conversations and invest in the teams where there is genuine capacity gaps, and where there's not, there's other discussions to be had. And that's kind of just how that's where we're trying to get to, having meaningful two-way conversations around accurate data. So I'll leave it at that, and genuinely thank you for the opportunity to speak today.
Thanks very much, Yvonne, and I agree with you. In most things, I think if you have the information available, it's much easier to make a decision. Ken?
Yeah, well, I'd just like to thank the two main speakers and Yvonne for your commentary. They've been really inspirational talks, and I really think they set the scene for what healthcare should be, certainly in this country in the coming years. So I thank the speakers. We're bang on time. We can now offer all the attendees, I think, a 6-minute comfort break, and we'd ask you to be back at 15:50. Thank you.
Thank you.
Thank you.
Good afternoon, everyone, and welcome to session 2. On behalf of myself and my co-chair, Mr. David Moore, I'm delighted to welcome you to this session and to welcome our first speaker, who is Mr. Derek Tierney. Derek is Assistant Secretary at the Department of Health, and he's Head of Health Infrastructure there. He's had a 30-year career, which started initially in the private sector, working in pharmaceutical and electronics manufacturing industries, as well as the telecom sector. In 2001, he moved to the commercial semi-state organizations involved with construction and operation of the Lewis. In 2012, he was funded to the Department of Finance to support not just the government's response to the mortgage arrears crisis, but also to help address the many challenges faced by our country at that difficult time. Since 2016, Derek has held leadership roles in the Department of Transport, in capital infrastructure, in the Department of the Taoiseach, developing a whole of government response to Brexit, and in the Department of Justice to support organisational transformation. More recently, he was appointed by the government as the Programme Director of the COVID-19 Vaccination Task Force in November 2020, where he provided strategic support to both the Department of Health and HSE. Derek has since then joined the Department of Health in June 2021, where he is responsible at Assistant Secretary level for the development of a strategic approach to the delivery of capital health infrastructure, including e-health and ICT. Derek, you're very welcome to RCSI. Thank you very much for taking the time to join us this afternoon, and we look forward to hearing from you.
Thanks, Deborah. I'll just launch my presentation and we go from there. So good afternoon, Deborah and Kenneth and colleagues, and thank you for having me here this afternoon. Today, look, I just want to really dovetail within the context of the programme, and particularly the two earlier presentations have resonance in where I want to take my focus for the next 10-15 minutes, which is in the area of e-health, ICT infrastructure and integration. And I suppose really to run through framing e-health and what is it, ICT infrastructure integration, and particularly e-health has become very topical in the very recent past and months, and therefore maybe just set a strategic context in where it fits or sits, and a deeper discussion into e-health and ICT, and particularly looking at where have we come from, where are we now, reflections from COVID-19 as a great disruptor in the context of the status quo and how we've provided services to date, not just in the health sector, of course, but right across government and public services. And then tapping into some of Martin's insights into around health data and information and how we should use that as a strategic asset, and how it can help inform both policy, evidence-based decisions, but also making the case, and particularly in an area where the health sector itself has to compete against wider interests and defined resources. And lastly, really just to spend a bit of time to look at, well, where to next, both in terms of short-term and a longer-term outlook. So just in terms of framing e-health, and there isn't any singular definition around e-health and or the use of e-health in the context of deriving or delivering public health services, but I'm going to pick up on two which probably have resonance in I suppose in terms of how we in the department and in the wider health service and through engaging with colleagues in the HSE look to the whole area of e-health. The WHO, of course, defines e-health as a cost-effective and secure use of information and communication technologies, and that's not just restricted within the provision of healthcare services, but it's the wider use in the health sector. And more recently, the European Commission defined e-health as the use of ICT in health product services and processes, combined with organisational change. So again, just touching on the area of reform in healthcare systems and new skills, and ultimately how it interacts between patients and health service providers and institution-to-institution transmission of data or peer-to-peer communication between patients and their through definitions and compounding them gives us a perspective to reimagine or reframe e-health going forward. And I suppose we're starting to derive a view around e-health as the digitization of health services and processes, so that the right data about the right patient is in the right place at the right time, to ensure safe and efficient provision of integrated patient care services. And so really echoing, I suppose, Sláinte Kerr and the principles espoused in Sláinte Kerr 2017. I suppose if we're looking and taking a step back a little to look at the strategic context, I mean, the health sector is defined by a myriad of key sectoral policies and strategies, including some that you'll be familiar with. And I haven't set them all out here, but it is a very complex policy landscape and strategic landscape. And it's really confined and governed through government's national planning framework and the National Development Plan. And the National Development Plan itself sets out a gross vote allocation in the context of capital investment, which largely supports the delivery of IC and e-health, not exclusively, but largely. And looking at the next 5 years in terms of framing our ambition and the resources that we will be allocated to just under 5.7 billion. There are a lot of competing priorities, but within the health sector, and then in terms of how the health sector competes for wider government funding. And therefore, the key challenge is going to be matching demand for services with finite allocation. And I suppose really what I wanted to do is just give you a sense within that. If I looked at the next 5 years, and we looked at, I suppose, what do we see right across healthcare investment, and I'm talking wider than just e-health and ICT. We can see that the allocation is probably just under €1 billion per annum, and that's steady state. And that makes it, I suppose, challenging in terms of where we want to go. I just want to pick up on some notes as well, if you don't mind, guys. And that will grow that will grow year on year, and we only really start to see headroom in terms of additionality or adding more capacity, whether it's through non-ICT and e-health and e-health and ICT programs. And that competes in an environment as well, where we've one existing mega project underway, one probably in the pipeline, and a number of large-scale projects coming at us as well, whether it's the maternity co-location, the trauma strategy, and realising that, dedicated elective care centres in Dublin, Cork and Galway. And also we have ongoing capacity projects to deliver wider acute capacity, including refurb and new infrastructure, outpatients, rehabilitation, upgrades, theatre capacity. We also need to be able to demonstrate that we can also provide regional balance. So I think going back to one of the earlier comments, whether in Richard and or Martin's slide around equity of provision of investment and services ultimately, and how we demonstrate regional balance. And even outside the acute sector, we also have competing priorities in the context of enhanced community care, primary care centres, oncology, community nursing units. And then lastly, but not leastly, into the whole area of our equipment and diagnostic replacement programme and e-health and ICT. So quite a busy agenda in terms of investment, and ultimately trying to derive a very strategic approach to how we allocate finite resources within a wider sector. I suppose, where have we come from? And this is important. If we go back to 2013, which looked at the publication of the e-health strategy as it was at the time, ultimately we had a total revenue funding to match that ambition at the time, comprising of around 167 million euros, 40 million of which was capital, 127 million of revenue. And that capital was mostly focused on core infrastructure, so the nuts and bolts and the hard wiring of the system. But really looking at how we invested, it was largely tactical in nature and very much on a fractured basis. The e-health strategy was published and set out ambition, and one of the central tenets was a national electronic health record, and that has subsequently been supported by Sláinte Kerr and government investment. But like in terms of a real-time basis, we will only see the role of an EHR starting with the Children's Hospital in I suppose on a mainstream basis, and then looking to push that out in a wider program of investment over the next decade. And we also have to, I suppose, engage with our colleagues in the Department of Public Expenditure and Reform and be able to show form and demonstrate confidence that we can deliver such large and complex programs over the next time horizon. I suppose, where are we now? Well, look, capital and revenue funding has increased steadily since the publication of the 2013 e-health strategy. And I suppose that's because we've been able to make a convincing case, A, of the underinvestment, but B, that we do need to invest to achieve government ambition in this space, and that does take money. And again, just looking at where we've come from in 2013, from a total investment portfolio of around 167 million. We've now grown that to 333 million, which is quite significant. There have been dramatic developments during COVID, and that has, I suppose, driven innovation, and not only encouraged it, but it was essential, I suppose, in terms of being able to move and to be able to deal with the pandemic as it unfolded. The recognition of the importance of managing data and information more effectively, and not just, I suppose, to labour on the performance management element of it, but again, really to interrogate and provide evidence, and real evidence to underpin policy and making the case. But we can see that as well, the importance of managing data and information being adopted by the public, particularly around being able to inform of what's unfolding and to be able to, I suppose, provide confidence in terms of the delivery of services. Also to use that to inform policy in terms of how we modelled our responses. And a key, I suppose, in my mind would be test and trace program and managing the national vaccination program, and ultimately repurposing medical information to provide an additional public service through the issue of the digital COVID certs. So again, the department through government have secured and approved funding for a doubling of the requirements in ICT and health, and translating that into the doubling of the workforce, particularly in the technology side of the HSE in the context of rolling out ICT and e-health. We can't not sit up and take note when we just see the complete and absolute impact that the recent Conti attack had on the healthcare sector. And that is now a real cyber threat landscape. And we've had subsequent I suppose, events since, and we don't just see that here at a national level. We can see it right around the world, where the health sector is quite vulnerable just in terms of how it's constructed, and provides, I suppose, opportunities for criminal or other actors to expose that vulnerability. And lastly, I suppose, in the context of where we are now and looking forward, the health service has to compete with the rest of a wider tech sector for skilled resources in Ireland, and that's finite. And that will be a rate limiting factor. So that suggests a need to look at how we evolve our skills curriculum and working with other partners across government, particularly higher education. I suppose if I was to look at the last 2 years and look at reflections from COVID-19, there are some key learnings that we need to reflect on and embed and build from, I suppose, in terms of moving forward. Clearly what we can see on the ground in the context of delivering health services, co-design was key, both clinical and technical teams working very close together to develop solutions, and actually developing in a very agile environment. Going back to something that Yvonne said earlier in her closing remarks, we shouldn't be looking for perfection here. We should be looking for agility, learn from lessons and try and evolve that and ultimately scale it, but to bring that benefit. The crisis created a lot of opportunity for us as well, in the context of how we deliver health services, but ultimately how we, in my mind, started a conversation with the wider public through the development of health provision platforms. A key part of that was, again, looking where the public were very prepared, but to provide PPSN and other personal details, which enabled individual health identifiers to be deployed, particularly in the vaccination program. And these identifiers are a foundational component for electronic health records and rolling that out. And I suppose that's a key enabler that we need to build off. We also were quite successful in building, I would say, European class and best in class citizen-facing solutions that were adopted again and embraced by the public, whether that was HSE Live, self-registration for vaccinations and EU COVID certs, and of course the COVID Tracker app. So they're just, I suppose, evidence or demonstrating that, you know, where there is purpose and unified purpose, and where we can I suppose, show the benefit and the outcome to the end user, and ultimately it leads the public or the patient in this regard. Our services and the development of applications to deliver services, particularly through eHealth and ICT, are adapted and will be adopted by the ultimate end user. And for me, this is one of the clear demonstrations that it is possible to deliver eHealth solutions quickly, and maybe contrary to some of the narrative that abounds in the context of the status quo and the ability of the health sector to reform and transform. The second area I suppose I really wanted to spend a bit of time on, and I suppose it is a backdrop to some of the work that Martin is doing, but not in whole a whole backdrop around performance management, but it's looking at the whole area of health data and information as a strategic asset. And when we stand back and when we look at I suppose the current landscape or the health data and information landscape, it is quite fragmented, and there is an embedded culture of not sharing beyond individual healthcare facilities or providers. And I suppose it goes without saying that the private-public divide further exacerbates the information challenge that we face, and particularly if we want to look at data and information share that is patient-centric or patient-focused, or looking through the lens of the patient need in terms of integrated care and their health journey. The WHO made recommendations to Ireland and have identified priorities for the improvement of the national health information system, and therefore we are tasked and challenged with implementing those. I suppose legal considerations and patient consent and patient right are often cited for lack of information sharing. But again, just going back to the experience throughout the pandemic, and more recently some work undertaken by HICWA, suggests people are very willing to share the data for legitimate purposes. And if that purpose is set out in advance in terms of transparency and very clear I suppose information provision to begin with. COVID-19 also highlighted deficiencies in how we structure and our health data. For example, particularly around the vaccination program, when we looked at some of the earliest cohorts and when we were prioritizing the deployment or the administration of vaccine in the early days, it wasn't very easy to identify and, more importantly, locate priority cohorts for vaccinations. So when I talk about central disease registers, or when we look at those with the most pressing medical need, how we identify them quickly and how we locate them quickly has been a challenge, and that's something that we do need to take forward in the context of how we use health information and data. And lastly, I think it equally identified opportunities to adopt and embrace this agenda. So I would say that there's a collective need to build on this, as integrated care will not be possible without integrated data and sharing of same. So I think how do we move forward in the context of health data and information, and particularly looking at it from the patient's perspective in the context of integrated service delivery and healthcare delivery. I suppose moving forward, the view is emerging that sharing of the data will require an overarching policy framework, and that needs to be underpinned by a legislative basis. And moving beyond just GDPR as a legislative basis, it'll also require new governance arrangements and structures. So some of the early policy thinking within the department, and we're starting to consult with stakeholders right across the health sector in this regard, is about using and providing for the use of PPSN across the wider health system, and anchor that as part of the health identifier at a patient level. Regulate and direct the flow of information through the health system to support the integrated model of care so that data can follow the patient. Facilitate a national data centre for secondary purposes. So think of this as a CSO for health. As Martin said earlier, and I think Richard picked up on the point in the context of big data and being able to leverage big data to derive insights, whether that's early diagnosis or early treatment, but also just being able to join the dots in the context of patient need and how a patient moves through a healthcare journey from prevention right the way through to intervention. And facilitate the appointment of a national data governance board and a national data guardian, I suppose to coalesce stakeholders and needs in this area and ensure that we deliver on any mandate and any ambition about using data and information as a strategic asset. And secondary to that, build public confidence in how health data is managed so that there is transparency around its use and that there's confidence built from a public perspective in how health data is both secured and transmitted or transferred or managed. And lastly, and I can't really underscore this, just particularly from my perspective and where I'm sitting at the moment, it's using data as an evidence base for future policy decisions, but also to be able to make an evidence-based case for investment. And when I'm competing against 16 other government departments, that is key because there are finite resources. Government thinks about investment as a wider portfolio, and we have to compete for investment. And ultimately, if we want to grow our ambition and grow our investment portfolio beyond 5.65 million in the next 5 years, it's to be able to make the case for investment with clear evidence and rationale for that. I suppose, how does the department enable e-health, ICT infrastructure and integration? I think it's moving from more than does to how it will, and we're taking a very proactive, deliberative role in this space. Well, I guess our mandate will be to support transformation of healthcare delivery through driving the digital agenda in healthcare. And I'll touch on that later in probably some of the wrap-up slides. How do we do that? What are our hooks? And how can we position ICT and e-health for healthcare in the context of wider needs? Encourage innovation that is impactful and scalable. And I suppose really here it's about a reality that's seeded first and scaled in the second instance, and not I suppose grounded in reality. Not in checks that nobody can cash through, I suppose, describing ambition that might be decades away, but we have to be very determined, strategic in our approach and directful in terms of how we move and encourage innovation that we can scale and act as an enabler through, again, policy and strategy development and co-design. Particularly in my career, what I've learned to date is strategy is great, it'll only exist on a shelf if it isn't shared and if it can't be delivered or actioned or translated into action. And to do that requires all stakeholders to walk the journey in terms of realizing the strategic intent. The department has a key role in deriving legislation and regulation. And just by way of example, at the moment, we are working on a heads of bill on the health information bill, really just to, I suppose, be very determined around how health and information sharing across the health sector supports the e-health agenda. And again, another example will be the regulation of medical devices and looking at advances in technology and process and system in that regard. Our role is to secure funds, provide sanction and resources through the HSE, through the hospital groups, through the CHOs, and ultimately trying to win a share and a wider share in terms of competing for resources across a broader picture. And allied to that, then it's to understand how we prioritize and direct areas for investment. And in a wider European context, it's engage and leverage other e-health networks and access wider networks and funding streams, whether it's the National Resilience and Recovery Fund, whether it's WHO funding, whether it's wider funding. And we shouldn't just look at national funding programs. We should be looking to leverage as much as we can and as wide as we can. And we have quite a bit of capital built in fair reputation and due attitude in our wider European health networks. So it's incumbent on the department and working through the sector as well to leverage that and see what we can win and attract to support our mission. So next steps, and what are the next steps in terms of where we've come from, where we are now, and pausing for reflection. What do we think and where do we think the next steps are? I suppose firstly, it's really around updating our e-health strategy 2013. It's almost a decade old at this stage, and we need to widen the ambition within the e-health strategy in terms of scope and breadth and depth to look at the area of e-health, ICT and digitization. Today, government will publish their Harnessing Digital, the Digital Ireland framework. And we have had an opportunity to feed into that and position health within that context. And I would be remiss without saying on this call that the provision of healthcare and health services and digitised healthcare and health services is very much underscored in government's strategy delivered today. So that's a great opportunity, I suppose, to look to see how health can play its part in the digital Ireland framework, and how we can achieve support. Yeah,
Derek,
sorry.
I'm sorry, can you hear me? It's David Moore here. Could I ask you just to kind of complete your talk, please? We're just in danger of running over time.
No problem.
Thank you.
Not at all, David. So very quickly, any evolution of the strategy, we've got to make sure it's outcome focused and it can't be fractured and unintegrated at a point of service perspective. Picking up on Richard's earlier comments, be able to respond to advances in technology, robotics, digital and use of digital and virtual twinning, use of data to derive evidence-based decisions and making cases, and allow for that flexibility, cater for evolving patient and clinician requirements. And lastly, integration has to be at its core in terms of how we integrate governance approaches, system architecture at a very clear level and all definition. And then ultimately, and I won't go through all of this, but just to wrap up, structure that around delivery timeframes and horizons that are goals and target driven rather than just aspirational or ambitious, and derive those horizons, both short term, medium term and long term, and that overlap, but ultimately deliver an ambition over the next decade. So again, I'll just wrap up there, Kenneth and Deborah, and thank you for your time and the invite today, and for the audience for listening.
Well, thank you very much indeed, Derek, and I'm sure there'll be a lot of questions. I'm going to hand over to my co-chair, David Moore, for the next speaker. Thank you.
Thanks, Debbie. Thank you very much, Derek. We're going to move on now to the section entitled Optimizing Surgical Work Practices, and we have two speakers here. The first is Sven O'Haraboyne, who's a consultant orthopedic surgeon in the Mater Hospital. Sven has very kindly agreed to give this talk and a second talk in a few minutes, because Joe Butler is stuck in surgery and will be unable to give his own talk. What I would propose is that Sven will give his first talk, and then we move on to the second talk by Liam Murphy, and that Ken will immediately then just progress to his third talk, his second talk, and then we'll move on to the neurosurgical presentation. So Sven completed his higher surgical training in Ireland and received the Sir Walter Mercer Medal for the highest mark in the FRCS in the UK and Ireland. He then completed a 6-month fellowship in arthroplasty in Northern Ireland before doing a 2-year fellowship in trauma and arthroplasty in Toronto, in Sunnybrook and St. Michael's Hospitals. He's going to talk today about Cyto, which is a secure medical messaging app that connects healthcare professionals to one another. And certainly a lot of people will have had some experience of it in the recent pandemic. And today we understand that Cyto is the largest medical network in Europe with over 300,000 members who have so far exchanged over 500 million messages. The second talk will be given by Liam Murphy on the subject of T-Pro, which is a global leader in clinical documentation improvement software. It's an Irish-based company with digital solutions in 38 of the 42 HSE sites present. Liam is the sales manager presenting this afternoon and will talk to us about optimizing surgical work practice with AI-powered speech recognition. So maybe we'll ask Sven to give his talk, then Liam, and then we'll come back to Sven. Thank you.
Thank you, David. I just share my slides here. So as Dave Moore already mentioned, Cyto is a secure medical messenger app. It's end-to-end encrypted. It provides a secure library for images, so you can post x-rays, clinical photos, etc. to go with any case. It is GDPR compliant. It's approved by the NHS in the UK. And all users on it are verified and have to go through a verification process before they have access to it. So that's, I guess, where it differs from the social media apps that perhaps some people have been using, though strictly speaking shouldn't be using. So in comparison to, say, WhatsApp, it meets all the criteria for security and confidentiality that WhatsApp doesn't. So really people should not be using WhatsApp, and Cyto or a similar alternative should be the choice. To give just one concrete example, and we have many different Cyto groups, so I'm going to talk a little bit about the hip fracture group, but for example, we also have a group for day of surgery admission patients for scheduling and organization around that. We have another group for ED trauma referrals and a further one for inpatient follow-up. But just to give one example of how it works, there is a hip fracture group in the matter. On that, we have members of the hip fracture committee, orthopedics, as well as orthogeriatrics, representatives from anesthetics, the theatre coordinator, the orthopedic ward, and the, sorry, are my slides not sharing?
No, no, Sven, they're not.
Oh, okay. Let me just try that again. I did click share screen and it worked earlier on the trial run. Let me just try that again.
Yeah, that's perfect. Now. Thank you. Yeah.
Okay. Apologies for that. So we've covered that. So I said that these are the members of the hip fracture group that we have, and the theatre coordinator is also on the group, the orthopedic ward, which is St. Agnes's, and the site nurse manager. So then when the ED doctor posts this, and I've not picked a particular case, this is genuinely the last posted hip fracture case prior to making these slides. In the interest of fairness, I didn't cherry pick a good one or anything like that. A concise, clear history like this is posted. The patient, the ED doctor posts the plan, so you can see there the ECG is done, the basic workup is done, the block is being prepared, and all the information needed to make decisions is there, along with an X-ray, which I haven't posted, but an X-ray confirming the said hip fracture. And you see a response here, and apologies to the doctors whose names appear. Obviously, no patient names appear on any of this. So you can see there the COVID swab is acknowledged, and that's been expedited because the site nurse manager is on the group. He or she can immediately then see that COVID swab is a priority and clear that being expedited. You can see that the time of registration there is mentioned, so 21:24 was the time the patient registered. There was a pre-alert from the Dublin Fire Brigade, which helps obviously. And by 22:59, so within an hour and a half, a bed has been allocated. So it really helps streamline that whole process, and everyone who needs to know knows at the time of registration. So there isn't a trickle down of information where the ED SHO tells the reg, who tells the orthopedic SHO tells his reg, who then has to do all the paperwork before somebody thinks of calling theatre and the ward, etc. It's all done immediately, and all the people who need to know right away. And you can see that this graph is somewhat embarrassing reading for the matter, but this is the graph from the hip fracture database showing the percentage of patients who are meeting standard 1 of the hip fracture standard. So standard 1 is admission to an orthopedic ward within 4 hours of registration. And you can see the sort of turquoise bars there are the 2018 figures. And in the matter in 2018, 1% of our hip fractures met that standard. So really quite embarrassing figures, and one of the worst in the country. By 2019, with the introduction of Cyto, we had improved, not to the point where we'd be crowing about it, but we'd improved to 17%, which is quite a dramatic improvement, and we've seen sustained improvement since then, with some dips due to bed availability with COVID, but generally we've seen sustained improvement since then. So that, just in a graph form, shows us the percentage of patients who are meeting standard 1 before the intervention of using Cyto, and this was following the integration of Cyto. So still work to be done, but quite a dramatic improvement based on one very simple technology. And we see here a month-by-month basis now. June is an aberration there due to multiple factors. Quite a small sample size. There were quite a few hip fracture patients in June. An issue with beds again due to COVID, but you can see generally a steady increase in compliance with standard 1. So that's just one example of it at work. It works for the trauma referrals, as I say, and we use it for following up our inpatients as well. The advantages are it's secure, it's compliant. It isn't necessary to go through each chain for everyone to be informed. Everyone's informed simultaneously. The silo conversation is automatically deleted after 30 days. But in instances where you want to record in the medical notes, it can be saved as a PDF, printed and scanned into the patient center notes that we use in the matter, or physically printed and put into the charts. And it's also very good for oversight as a consultant when the NCHDs are making decisions on call, whether that be hip fractures or other trauma. We can allow them a degree of autonomy where they can make their decisions without directly consulting us. But if a decision is going to result in a delay in care or appears inappropriate, we can intervene either directly on that conversation or quietly on the side to the NCHD in question with a bit of advice. And that's quite a useful feature of it. Obviously, there are some downsides. Need to be aware that there are quite large numbers of users on some of these groups. If we include all these people, to be sure that there isn't a sharing of excessive amounts of information with an excessive number of people in a way that is not in keeping with patient confidentiality. Obviously, it's important that people remain professional in the discourse and remember that it is a legal document, and just because you're texting on your phone essentially does not mean that it's not part of the patient note and isn't something that needs to remain, as I say, very professional at all times. And I suppose the other downside, and I'm stealing a bit from Joe Butler's slides later on, is the idea of cyto fatigue, that when there are so many groups and so many referrals, it can be a bombardment of messages, and you need to just find strategies for managing that, whether it's muting your notifications when you're not on call or just limiting the number of groups you're involved in. So short and hopefully covers what we need there. I'll hand back over to Mr. Moore.
Thank you very much, Sven. We'll move directly on now to Liam Murphy, who's going to tell us about T-Pro, if that's okay. And Liam, I presume you will have some slides. You might just confirm that.
Yeah, I do indeed, David, thanks.
Thank you.
Yeah. Might just confirm actually that you can see what I have on screen.
Yes, perfect.
Yeah,
thank you.
Brilliant. Okay. So thanks very much for being given the opportunity. So my name is Liam Murphy. I'm the sales manager at T-Pro, and the topic for today's webinar is to discuss how surgical work practices can digitally transform administration processes with AI-powered speech technology, and more specifically look into how this technology can support the delivery of innovative, safe and high-quality patient care. So I guess, why does speech-enabled clinical documentation make sense now? The pressure is on for surgical work practices to improve the quality of clinical documentation, ensuring continuous, uninterrupted patient care, especially during difficult times. And for surgeons and other healthcare professionals, high-quality, accurate, up-to-date patient records enable better teamwork and collaboration, support for point-of-care decision-making, and boost efficiency, enabling clear and complete information exchange in a timely manner. And for patients, access to their own health data is key. Complete records enhance communication, trust, and continuity of care, leading to better outcomes and improved safety. For everyone in Ireland's healthcare system, comprehensive clinical documentation makes claiming and budgeting more efficient and improves regulatory, legal, and financial reporting, and sharing relevant information with GPs easier. So why does speech-enabled or speech recognition clinical documentation make sense for surgeons and other healthcare professionals? The time healthcare professionals dedicate to interacting directly with patients is shrinking and can account for less than 13% of their day. And shockingly, research shows that in some cases, healthcare professionals spend more than 50% of their working day creating, reviewing, and updating clinical documentation. In America, a busy doctor can actually produce enough clinical documentation to fill 40 books of 400 pages each year. So this is the equivalent of 7.2 million words. Speech recognition technology allows healthcare professionals to capture patient data and complete clinical documentation more than 3 times faster than typing, and with greater accuracy and completeness. Sven, it might be interesting to see how we can improve clinicians' productivity using your app, if it's 3 times faster than typing. Using voice to text, users can navigate more quickly in the electronic documentation, use advanced voice commands to automate repeat functions or jump to specific screens within an EPR. They can call up pre-configured templates and associated documents and insert often repeated standard text. Virtually all mouse actions can be replaced with voice commands and tailored to create a completely personalized workflow. The use of speech recognition improves the quality of documentation by reducing repetition and the potential for errors and eliminating duplication of effort. Not only does it streamline the process of recording structured information and in forms in health records, but speech recognition can also encourage healthcare professionals to document the patient's story more fully. A UK study shows that 68% of clinical documentation is narrative-based, and the rate at which speech recognition converts voice to text demonstrates its potential to improve both the volume and quality of time available for patient care. A complete, detailed patient record that goes beyond basic facts makes it quicker and easier for healthcare professionals to share vital information and helps guide and speed the transfer of care as patients move along the care pathway. So from triage to consultation, referral, and discharge. A substantial 80% of healthcare professionals say good patient relationships are the most satisfying part of their job. However, many are becoming demotivated and frustrated because of administrative overload and a consequent lack of time to spend with patients. Speech recognition improves the day-to-day working of lives of healthcare professionals by enabling them to produce real-time, detailed, accurate clinical records as quickly as they can think and speak. It puts them in control, giving them more time to focus on patients, confident that the documentation they produce sets the standard for a better quality care. So what about patients? Very briefly, using speech recognition, this frees healthcare professionals from significant red tape and gives them more time to observe, listen, and interpret the patient's stories, putting the patient firmly back at the center of care. Speech recognition also encourages complete capture of the patient's story, both the detailed narrative as well as the structured data preset forms and templates require. For complex cases where patients require multiple treatment protocols and the support of multidisciplinary teams, the whole team benefits from having a fuller and more accurate picture of the patient and their needs, which leads to improved team coordination and better results. So for the Irish healthcare system, digitised clinical documentation is the cornerstone of Ireland's vision for a fully integrated e-health network that will deliver productivity benefits for healthcare and quality outcomes for patients. There are, of course, technical and cultural barriers to the uptake and adoption of e-health and other shared care record systems, but simplifying and naturalising the user interface using speech recognition to input the data ultimately removes the greatest barrier of all, which is overloading the healthcare professional with more administrative red tape. Speech recognition is fast becoming one of the most used tools in the quest for e-health adoption because it improves clinical documentation, allowing clinicians to document the encounter anywhere, at any time, and on their preferred device, which ultimately improves efficiency, staff productivity and turnaround times, and as well as employee satisfaction. So obviously, as a result of COVID, Irish doctors are exhibiting high levels of burnout, including emotional exhaustion and cynicism. And almost half of young doctors actually may be suffering from burnout, according to a recent survey. During the pandemic, Irish healthcare workers self-reported moderate to severe symptoms of depression, anxiety, and PTSD. A recent study in the US, however, showed that nursing staff using front-end speech recognition has spent less time in documentation and completed their chartings more quickly. Healthcare professionals can begin to feel better about documentation, more in control and more satisfied at work. They feel more confident about technology and have a better user experience. For all of the above reasons, speech recognition is rightly regarded as a possible solution. At T-Pro, we offer speaker-independent AI-powered speech recognition. That means users are not required to train the software and will have a highly accurate speech recognition conversion tool. We handle sophisticated medical vocabularies and appropriate medical terms for each specialty by combining speech and natural language understanding technologies to contextually understand the clinician narrative for out-of-the-box accuracy and performance. We provide and support flexible workflows for speech recognition, as we understand when it comes to speech, it's not a one-size-fits-all. So we provide a solution-based technology with the goal of offering end users choice and options without forcing them into a particular mode of documentation. So that may be using, for example, a mobile app to dictate using back-end speech recognition, which sends to medical secretary or designated typing pool to edit the speech recognition on behalf of the clinician. Whereas a more tech-savvy clinician may actually wish to use our front-end speech recognition, which allows them to convert speech to text in real time using any web application or directly into the patient record system. Our speech recognition can be utilized across all clinical workflows, care settings, devices, and apps. So some examples of T-Pro's versatile workflows for speech recognition include the following. So front-end speech recognition allows healthcare professionals to produce clinical documentation directly in the EPR or any other clinical system. So using a small, non-intrusive dictation window, healthcare professionals can access their voice profile anytime across a variety of devices and verbally or use their voice to create, edit, and sign reports directly in the EPR or any other non-clinical system, like, for example, Microsoft Outlook or Word. T-Pro is a mobile-first speech recognition solution, which lets healthcare professionals produce clinical noting or all document types, for example, post-op and ward round notes using their preferred mobile device. So they're not confined to dictating just at their desk. They can dictate at the point of care using their preferred mobile device. Clinician engagement and satisfaction is greatly enhanced by giving access to key demographic and clinical data, enabling them to safely identify patients and dictate and approve clinical notes at the point of care. For clinical correspondence letters, we provide intuitive tools for clinicians to dictate using speech recognition. They can review, edit, and electronically sign documents and use intelligent automation tools to streamline workflow processes. T-Pro's national integration with PAS systems like IPMS streamlines the clinical correspondence process, instantly populating with relevant patient demographics as well as clinic visit information. And this is particularly important for when using speech recognition, as it significantly reduces or improves the recognition accuracy scores by eliminating or removing the need for the clinician to have to dictate the patient's name, address, and other clinical or visit information, which is, as I mentioned, just automatically populated. They have the option to self-edit and sign the reports themselves in real time, or send to a medical secretary to review on their behalf. Once signed, we can automate the electronic distribution of clinical correspondence to the patient's GP via our national integration with HealthLink, which electronically sends a copy of the correspondence letter electronically to the GP, and this is instantly. And there's several hospitals already using T-Pro for the speech to text conversion tool, but also to electronically distribute correspondence letters, which is then instantly received by the GP. So I'm just conscious of time. I'm going to end my presentation abruptly, but for those of you who would like to, see any of the attached case studies that we have on various different hospital groups, including one of our blue ribbon clients is the Galway Clinic, which T-Pro helped them achieve HIM Stage 6 accreditation. So T-Pro played a huge part in enabling them to achieve paperless workflows using our mobile-based speech recognition solution. So any questions, please just let me know.
That's great. Thank you very much, Liam. We'll move on now to Sven O'Herborn is going to give us a second talk on behalf of Professor Joe Butler, who has been detained in theatre. And Sven is going to talk on the orthopedic aspects of using the Nimitz system for imaging in trauma.
Okay, so you got my slides this time?
Yes.
Okay, so as Mr. Moore says, this is on behalf of Joseph Butler, who is detained, but the slides are fairly self-explanatory, and they're more about the systems in use than any complex spine stuff. So there, as most of you be aware, that the matter is the National Referral Centre for Spinal Injuries. So the pathway in place at the moment is that the reg in the referring unit will call the spinal reg on call. The case will be posted on a Matter peripheral hospital silo group. So that'll be contain the images, the patient details, and so on, as shown in my talk. And then the imaging, local imaging, will be available in most cases on Nimitz. Now, obviously, there's an issue that not every hospital uses the Nimitz system, and there are outliers to that, which results in difficulties in the need then for physical transmission of images via sending discs and things that hopefully could be dealt with by appropriate information technologies in the future, or the adoption rather of Nimitz by all. And then the Matter reg will then discuss with the appropriate consultant on call on an internal silo group. And the Matter reg will then relay the plan, any further investigations required, and so on to the peripheral hospital, or a decision to transfer if immediate transfer is the decision. So I already gave my pros and cons on silo, and I suppose this is Professor Butler's take on it. So it allows for national referral pathway. You can be accessed from your mobile, and anywhere where you have internet cover, you can access the information or scans. You don't need to be in hospital or at a monitor. It's useful for documentation, as I mentioned. It can be put into the patient's chart. This is something you have to choose to do, though. It's important to say this isn't automatically at the moment part of the patient's chart. You need to create the PDF, which is simply a question of clicking one button in the app, and then scan it in or print it. And it's useful for a teaching tool. You can go back over it and reflect on the process and where things could be streamlined or improved. And also, the referring clinician can receive kind of information or education in the case that's an NCHD. It can be useful for teaching in that sense. The cons, as I mentioned, cyto fatigue. So there can be a bombardment of messages from this, and if it gets to the point where people disengage from it, that's obviously counterproductive. So it's important to try and keep the conversation somewhat streamlined and use it only as appropriate. And it doesn't replace face-to-face discussions, clinical examination, all those things, and often there's a need for multiple consultants to be involved in the decision. All that obviously doesn't necessarily take place in silo, so there's still low-tech procedures involved. And again, this is an example of a referral that might come across. So somebody with worsening back pain, fecal incontinence, a query of cauda equina, and that's how it would be referred. Just as we saw with the hip fractures, or indeed with trauma patients, a concise history with appropriate attached imaging. Then the pros of Nimitz is that it's in theory a national system. So in the Matter, the spine surgeon on call can look up the imaging from the referring center in most cases, and that patient's folder can then be updated and added to between hospitals, and be accessed from any of those participating hospitals, either the referring center or the receiving center. The cons are that obviously the quality of scans can vary locally, and the particular protocols for imaging in more subtle cases. And unfortunately, even though it's theoretically a national system in true Irish fashion, not every public hospital in the country uses it. Perhaps that's something that should have been mandatory, but unfortunately it's not the case. So here's obviously a case of a selected sagittal cut used. It is possible to load entire CT or MRI scans if you take a video of the scan and then put it on silo, but obviously access to Nimitz is much better than images can be appropriately manipulated using MPR and so on, in a way that you can't do on silo. So it is much more appropriate that these images in complex cases be reviewed on Nimitz. The associated MRI, again, just multiple different MRI sequences there. the ultimate treatment, so posterior stabilization. I'm not going to go through any of the specific cases. I don't think they add to the discussion, but just showing some of the type of cases that can be referred, and then ultimately the treatment of those cases. Looks like probably a percutaneous fix there. Then again, the spine tango, which I'm actually not that familiar with. Perhaps if there's anyone on the conversation from the spine side, they could maybe tell us a bit about that. I'm going to skip over that. Oh, sorry, here it is. Sorry, it's a standardized referral system here, which is essentially a tick box thing. It's good for completeness. It can be again recorded in the notes, and it's a standardized thing from the Eurospine group that's in use with the spine referrals. Again, it is a lot of additional administrative work. That's the downside, but as I say, it is a very complete system. It is very standardized, useful for research too, for that reason. And I'll just close there and hand it back to Mr. Moore for the panel discussion.
Thank you very much, Sven. I'll hand directly over to my co-host, Debbie McNamara, for the introduction prior to the final talk.
Thank you very much indeed, Sven and David. I'd now like to welcome Professor Mohsen Javidpour, who's a consultant neurosurgeon and clinical director of the National Neurosurgical Centre at Beaumont Hospital. Mohsen is a graduate of Trinity College Dublin, trained in neurosurgery at the Walton Centre for Neurology and Neurosurgery in Liverpool, and followed this up with subspecialty training in neurovascular surgery at Toronto Western Hospital in Canada. He was a consultant neurosurgeon at the Walton Centre from 2004 to 2011, and during that time held a number of prominent positions in neurosurgery, including as chair of the British Neurovascular Group, as a member of Council of the Society of British Neurological Surgeons, and he was also associate editor of the British Journal of Neurosurgery. Thankfully for Ireland, he moved back in 2001, and he currently is clinical director of the National Neurosurgical Centre and also an honorary associate professor at RCSI. He's a prolific author of more than 70 peer-reviewed articles and has written a number of book chapters, and we very much look forward to hearing from you today, Mohsen.
Thanks very much. Can you see my slides?
Yes, we can. Thank you.
Great. Thanks very much, Debbie, for the introduction. I'm going to talk about the use of imaging in neurosurgery. Imaging is integral to all of neurosurgery, whether we are talking about cranial brain problems or spinal problems. We really can't do anything without imaging, which you guys probably realize when you contact us. We always need to see the scan. You probably know, prior to imaging, neurosurgeons used to operate on people based on clinical symptoms and signs, either by examining them themselves or by a neurologist. And things have luckily moved on from then. And imaging is really used all the way from diagnosis into surgical planning, and also into the operating room in terms of image-guided surgery. It's all a part of neurosurgery. I do want to talk a little bit about neurosurgical emergencies as well. Just in terms of diagnosis, I'll just give you an example. The MRI on your left shows this abnormality on the right side, deep inside the brain. This is what we call a cavernoma, or a cavernous malformation. It's literally like a little raspberry in there, a collection of abnormal blood vessels. And they tend to just ooze a little bit of blood, then retract, and then maybe months later or years later, bleed again, and then again, and then again. And as a result, you end up with a patient that clinically presents essentially with repeated episodes of neurological deficit. So before the era of imaging, these patients were diagnosed wrongly as having multiple sclerosis, whereas in fact they have a vascular malformation on the right. You can see it at surgery. So you can just see how important imaging is in terms of diagnosis in neurosurgery. In terms of the operating, it's absolutely crucial. Imaging is now within our operating theatres. I don't really do any surgery without the use of image-guided surgery, of image guidance equipment. You can see a couple of examples of image guidance equipment on the right. The scans are obtained on the patient, very fine stereotactic scans, 1 millimeter slices, a day or two before surgery, MRI and CT, and then we import them into the image guidance equipment, fuse the images, and then use these infrared cameras and infrared spheres in the operating room with the use of the image guidance system to accurately localize the lesion. It has really improved the safety of neurosurgery. It prevents wrong side surgery because the software just won't work if you have registered the images the wrong way around. It allows us to operate through smaller craniotomy and using endoscopes, and the operation time and hospital stay are shorter. And the imaging that we use has become much more sophisticated. It doesn't just show us structures, but also function. So on the top left here, you can see in blue the fibers coming down from the motor cortex, so the corticospinal tracts that control movement. And we can actually use these images, the tractography as we call it, and functional MRI. As we look down the microscope, you can see on the picture on the top left, you can see, looking down the microscope, you can see the brain and an overlap of the structure, for example, a tumor that's been outlined based on imaging. And then the picture on the bottom right, you can see the tumor overlapped. You can see through the microscope, you can see the outline of the tumor, but not only that, but also in blue, you can see the motor fibers, and in green, you're seeing the vision fibers, the vision tract. So it's really made surgery a lot more safe. Not only that, we have moved on to having live imaging within theatre, because the image guidance equipment I showed you is really based on images obtained a day or two before surgery. On the top left here, you see what's called an O-arm. So it's basically like almost like an intraoperative CT scanner, which is used mainly for spinal surgery in Beaumont in terms of intraoperative localization. The picture on the right is an intraoperative MRI, which unfortunately we don't have in Ireland yet. The first one will go into the Children's Hospital, where you can actually obtain the MRI images live during surgery with the head open, so you can assess how much tumor you have removed during the surgery. So the old days were like this. You can remember these films, and when I was an SHO, one of my jobs the day before surgery was to make sure that I have all the scans available for the following morning, and if they weren't available the following day, that's how you felt. And we've moved on a lot from there, and PACS and Nimitz have helped very, very significantly in that. In terms of our operative planning, the stereotactic scans that we obtain a day or two before surgery can be loaded onto our image guidance systems directly. And what's really good about the PACS system or the Nimitz system is that it is national, which means that if you refer a patient to us, say from Letterkenny or Galway, we can actually, while the patient's waiting to be transferred to Beaumont, ask for the appropriate images to be obtained in the referring hospital, so that when we transfer the patient, we don't have to re-scan the patient. And that saves us about 500 re-scans per year. And it means that the patient's not sitting in a bed waiting for those MRI or CT scans to be repeated. So it has reduced the bed stay as well. In terms of emergencies, neurosurgery really is a collection of emergencies and urgent cases. More than 70% of what we operate on are emergencies. There is very, very little true elective cases in neurosurgery, probably just degenerative spine, lumbar discectomies and things like that. Anything else practically is emergency or urgent. This is a scan of an extradural hematoma on the left, and then on the right you can see a very swollen brain after removal of a subdural hematoma. And you can see very clearly the brain coming, extruding out of the skull, and you can see why these have to be dealt with very quickly, which means neurosurgeons do need access to the scans very quickly. A couple of other examples before I finish. On the top left is an aneurysm. The middle picture is a massive intracerebral hematoma with midline shift. And then on the right, you've got a very swollen brain at the time of surgery in a subarachnoid hemorrhage patient. And other examples are the top right is a tumor with midline shift. In the middle, you've got a patient with hydrocephalus, and bottom right is a caudal equina syndrome due to a very large disc causing compression of the caudal equina. Just examples of daily things that we deal with, which are all emergency and urgent, and all need access to imaging very rapidly. We have developed an online emergency referral system where you can put in all of the clinical history, and then we send you a reply after reviewing the scans. Image link was before Nimitz, where scans had to be linked to us. It's good, but Nimitz is much better because, as Sven said, we can actually look at the images as soon as they're obtained in the referring hospital. They're high quality images, and it allows rapid review and response, and it really has improved patient care. There are a few little downsides. The computers outside radiology departments are often not PAC stations, which means that they're slow. Archived images can take a long time to download. We often run into repeated freezing and have to reboot the computers, and all wastes time if you're doing a clinic of 35 patients where you need access to imaging. 2 or 3 hospitals are not on Nimitz, and I have no doubt that causes delay in patient care for the neurosurgical, both emergencies and also for discussion at MDMs. And I do agree with Sven, maybe it should have been compulsory. And the other problem with all of these technologies is the multiple logins that you have to do in each individual system that you're using, which wastes a lot of time. Finally, I think in future, it would be good to have systems that don't have any delays. Obviously, that would be the ideal, really fast systems. Ideally, you want one password that logs you into every system that you're using, be it imaging or your electronic records or your blood results or ordering system. And really Nimitz and your image ordering and your electronic patient records and the emergency referral systems all need to be able to talk to each other, and ideally secure access to all these imaging and electronic things on your phone. Thanks very much.
Thank you very much, Mohsen, for that overview, and I'll hand over to my colleague David for the panel discussion.
Thank you very much. Thank you to all the speakers, to Derek Tierney, Sven, Liam Murphy, and Mohsen Javadpour. We have run a little bit over time, so maybe we'll just limit the discussion to about 5 minutes. At the moment, I have a couple of questions. The first one, Sven, is for you. I'll paraphrase Jerry Kelleher's question. Silo is very good for shared decision making, but is there a risk that important clinical data is lost because of the 30-day time limit? And what proportion of the data that you have on Silo becomes part of the permanent patient records?
Yeah, and that's actually a very important question. I'd say that the Silo for now should absolutely not replace meticulous note keeping, because it is not routine for it to be kept in the patient's chart. That's something you actively have to choose to do, and there'll always be a chance that will be missed and that will be lost. I don't have figures to hand for exactly what percentage of cases that actually happens. Often if there's a kind of a sense at the time that this may be a controversial or complicated case, somebody will say, you know, that's one we should definitely print and keep. And until that's standard, I think it's absolutely essential that somebody doesn't feel, oh, well, I wrote it on Silo, so I'm covered. You're not covered. You need to keep meticulous notes until such time as that is routinely recorded.
Thank you. Derek, I have a question here from Kieran Ryan saying that Irish General Practice has had electronic patient records and integrated prescribing for a long time. What lessons can the Department of Health and the HSE learn and implement to allow the public sector hospitals develop technologically advanced services and still show deeper that there is good value for money?
It's a good question, David. Look, I think we just need to bring the e-health and ICT agenda to the fore in the health system. And as I said earlier, we've taken the opportunity to do that. Government today published Harnessing Digital Framework for Ireland, and we have the provision of health services and digital health services front and centre in that as an overarching ambition. So we have got government's attention. We are on the radar. Now we have to deliver on our promises. And to answer the question directly, we have to show form as a unified health sector and not one that is fractured and disjointed.
Thank you. Could I just ask Liam, if you're still there, the accuracy and of the voice recognition software, what sort of accuracy can we rely on? And is there an error that one of the problems is that people have to read again any of the dictation that they carry out? That's very time consuming. How accurate is the software? Okay, well, maybe
if he's not there as a regular user of it, every once in a while there will be a section of a letter that will come up as unclear. Now maybe that's just me, but that does happen occasionally. Otherwise the accuracy is pretty good. Occasionally the patient data is always right, but occasionally names in a letter, so somebody you're referring to or whatever, may occasionally be inaccurate, but generally health related terms are very accurate.
Okay, and the final question is from Cathal Kelly, our CEO in the RCSI. The recent pandemic illustrated that limited health resources or capacity have had an impact on the wider economy. Can this argument be made in arguing for increased share of government investment? Mohsen, would you like to comment on that?
I think the pandemic has highlighted a lot of the issues that probably for a long time we've been, if I'm allowed to say, shouting about in terms of both IT infrastructure, ICU beds. There's been a lot that has been highlighted in the past by clinicians, and probably the pandemic has brought it to the fore and brought it to the attention of the public and everybody else, and it is, yeah, I don't want to say it's a good thing, but I suppose it's a good thing that it has brought it to attention, and it would be good if more resources are put into things like the IT systems that we've been talking about, the imaging systems, and systems that capture data. A lot of systems are out there that are independently capturing different things, but we still don't have a really accurate way of capturing data, be it for planning purposes or audit or research. So I think from that point of view, yeah, the pandemic has certainly highlighted those issues.
Thank you. Okay, I'm going to pass back to Debbie now to summarize and bring the meeting to a close. Thank you very much.
Thank you very much, David, and thank you to the panel this afternoon. On behalf of the audience, I'd like to start by thanking all of our speakers for what were some really very interesting talks today. We're very grateful to you for making the time to join us and to share your knowledge. Obviously, behind a meeting like this, there's a huge team working, but I'd like to particularly thank Ciara Hughes, who's the program manager at NCPS, for her work in organising today's webinar. And I'd also like to acknowledge Ruth Kiley for her work. It's Ruth's first CPS annual meeting as a co-organiser, and I know that you'll join with me in welcoming her to the clinical programs team. We'd also like to thank Anya for her technical support this afternoon, as well as the RCSI events team. On a more general note, the clinical programs in surgery are a very important collaboration between the HSE and RCSI. And I suppose after such a forward-looking afternoon, It's sobering for all of us to remember that more than 350,000 people in Ireland are waiting to see a surgeon, and more than 71,000 people are on a waiting list for a surgical procedure. And so really we need to work closely together, and we need to do more to make sure that those patients and that every person in Ireland has access to the surgery that they need when they need it in a way that the country can deliver. We are hugely appreciative of the support that we receive from the HSE and the RCSI in doing our work. And I'd like to acknowledge and thank all of the team at the Clinical Program in Surgery, the Clinical Program in Trauma and Orthopedics for the work that they do on our behalf. At the HSE, we work closely with the National Clinical Advisor and Group Lead for Acute Hospitals, Dr. Mike O'Connor. And of course, we have close relationships with the Chief Clinical Officer, Dr. Colm Henry, and his team. At RCSI, our work is strongly supported by the President, Professor Ronan O'Connell, the Vice President, Professor Laura Vianney, and the entire Council indeed, as well as the CEO, Professor Cathal Kelly. We are especially grateful to the team in the Department of Surgical Affairs at RCSI, and especially Mr. Park Kelly and Mr. Kieran Ryan, who really relentlessly work on our behalf. And thank you both very much for all that you do. We do look forward to working with all of you in the years to come, and thank you very much indeed for joining us today and for your ongoing work in whatever capacity to improve surgical care to the people of Ireland. In finishing, I'd like to wish you a good evening and thank you very much once again for your participation.